A very good evening to everyone and a very warm welcome to everyone. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, sir needs no introduction at our platform, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned pulmonologist, Professor Dr. B.N. Prasad, sir. So there's MD in medicine, DNB in medicine, DTCD, DNB in respiratory medicine, DM in pulmonary medicine, MNA MS, European Diploma in adult respiratory medicine, FICP, FNCCP, FCCP USA, FRCP Glasgow, FRCP London, and senior consultant, pulmonary medicine, interventional pulmonologist at sleep medicine at Chinmaya Mission Hospital. With such wonderful insights, we are going to talk about the topic for today, which is management of hospital-acquired pneumonia. Before we move on to the session, let us have a brief look on what the topic says. So, hospital-acquired pneumonia is a significant concern in healthcare settings, typically developing 48 hours or more after admission. Effective management of HAP is crucial to reduce morbidity, mortality, and healthcare cost. In this webinar, we will be learning the management and hospital-acquired pneumonia and make a positive impact on patient care. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you. Please proceed.
Thank you for the wonderful introduction about myself and also about the topic. The topic of today's discussion is management of hospital-acquired pneumonia. Now, you all know that pneumonia is a very common condition. And when we think of pneumonia, we think of pneumonia which affects the young and the old, because this is the commonest infection among the young and the old. And most of these pneumonias that we are referring to, they are community-acquired pneumonias. The community-acquired pneumonias different from the hospital-acquired pneumonia for the very simple reason that the organisms which are responsible for the pneumonia in the community setting is different from the hospital setting. And most of the community-acquired pneumonia that we see, they are usually caused by the gram-positive bacteria, especially pneumococcus. And then, of course, you have viral pneumonias, atypical pneumonias, interstitial pneumonias due to atypical organisms which are present in the community. But when we talk about the hospital-acquired pneumonia, hospital-associated pneumonia, ventilator-associated pneumonia, here it occurs in a very specific setting. It does not occur in the community, and therefore those who get admitted in the hospital for some reason whatsoever, so they get pneumonia. So this is basically a secondary pneumonia which occurs in a hospital setting. Now, what exactly is pneumonia? Pneumonia is the infection of the lung parenchyma, a very simple term, infection. Now, when we call inflammation of the lung parenchyma, infection leads to inflammation, no doubt about that. But when we call inflammation of the lung parenchyma, it's called the pneumonitis. Pneumonitis. So, infection of the lung parenchyma. The lung parenchyma, you all know, anatomically, segment-wise, we have different segments. When there is involvement of your lobe, it's called the lobar pneumonia. When it involves a segment, it's called the segmental pneumonia. And when it involves the subsegment, it is a subsegmental pneumonia. And then when it's diffuse involvement, extensive involvement, not exactly involving the lung parenchyma, but the interstitium of the lung, it's called the interstitial pneumonia. And then it involves both the bronchi as well as that of the lung, it's called the bronchopneumonia. So this differentiation helps us to actually not only to understand the extent of the problem, but also we can place the etiology also based on the involvement of the various segments or subsegments, anatomical location of the pneumonia. It also gives an insight about the pathogenesis of pneumonia, because pneumonia means the organisms has to come from outside. Now it can come from the intestine, then to the blood, septicemia, you can have a problem. Or it can come from the air and it is in the nose and the upper airways, then aspiration, it gets into the lung. So, or when we do a procedures like bronchoscopy and other things, we may introduce the infection into the lung. So depending upon how the infection comes, suppose it comes from the blood, then you know there's a diffuse involvement, bilateral involvement, and there is basically interstitial involvement much more. For example, when it involves the airways and it occurs, goes in the dependent areas. So we can get an information from the anatomical distribution of the pneumonia, what is the source from where it has come. Now, when there is an infection to the lung, so naturally you will have an inflammatory response. Now, you all know what is inflammation. Inflammation is characterized by, increase in vascularity, there is increase in local temperature, and there is edema, there is congestion, and therefore there is pain, swelling, and other features. So, this is basically because of the mobilization of the cells, that inflammatory cells, and they release certain chemicals or cytokines and leukotrienes, whatever you call, which not only results in signaling pathway, but also they have a certain specific role in actually eliminating the infecting organisms by apoptosis or by complement activation. So there is destruction of these the organisms. So when there is an inflammatory response where there is a host and the agent interacts, so you have an inflammatory response. And this inflammatory response, when it occurs in the lung, so therefore it produces the typical features of pneumonia. Now, so depending upon the severity of inflammation, it can be mild pneumonia, it can be serious pneumonia. And we say severe pneumonia when it's life-threatening, and we have certain criteria to say what is whether it's severe pneumonia. And but most important thing is that severe pneumonia requires intensive care admission and high morbidity and mortality. Now, patient can be in the hospital, can have a hospital-acquired pneumonia, and later can be shifted to the ICU. So it is not that to have a definition or to diagnose hospital-acquired pneumonia, the patient has to be in ICU. It is not required. The patient has to get the infection in the hospital, as our compare has told that hospital-acquired pneumonia is the one which occurs after 48 hours after admission to the hospital. That means the organisms are not incubating. When the patient got admitted to the hospital for some other reason, at that time there was no organism which was harbored in the body. It was not there. Once the patient got admitted in the hospital, the patient got the infection from the hospital. So the hospital germs are different from the community, germs. That is what you have to understand. I've already told you the types of pneumonia. Community acquired pneumonia is one where there is no hospital admission, in no admission to come into the healthcare facilities, and by and large they're immunocompetent people. They are very immunocompetent people. Okay. Now, hospital acquired pneumonia means they have some problem. They have some comorbidities for which they have been admitted, and also their immune status may not be normal. Okay. Now, earlier we used to call hospital associated pneumonia, not hospital, healthcare associated pneumonia. Hospital is also part of healthcare. May get admitted to one small day for daycare procedures, or may visit one emergency room or medical inspection room, or OPDs, or can get admitted to some nursing home for a very short period for some other problem, and the patient has received some antibiotics. So that is healthcare associated pneumonia. The other one is that you are admitted in the hospital, so and get a pneumonia. That is a hospital associated pneumonia. Whenever you get the infection in the hospital, we call it as a nosocomial infection. A nosocomial infection, where the hospital fauna and flora or certain procedures which leads to the pneumonia, occurrence of pneumonia. And so the now that differentiation was there in in earlier classification pneumonia, that was as per the guidelines of various societies in 2016 and 17. At the time, they had included this hospital-associated pneumonia. Now it has been omitted from the latest guidelines because that there is no requirement to differentiate from hospital-associated pneumonia from community-acquired pneumonia because there is no incidence of MDR pathogens. Now, the multi-drug resistant pathogens is a hallmark feature of a hospital-acquired pneumonia. Okay, that too in the later stage of the hospitalization, not in the early stage of the hospitalization. Therefore, you don't have to confuse the whole issue and say that the patient has got healthcare-associated pneumonia. When you think of healthcare-associated pneumonia, the organism was typical to that of the community-acquired pneumonia. So, therefore, this terminology has been omitted. And now, hospital-acquired pneumonia, has already told, occurs 48 hours after admission, and the patient is not incubating the infection. And ventilatory-associated pneumonia means the patient has been intubated. Endotracheal tube has been passed. The patient is connected to the ventilator. And here, after connected to the ventilator with an endotracheal tube, if there is new opacities comes in the chest X-ray, and we think that it is due to the infection, then it is called the ventilatory associated pneumonia. Now, incidence of the hospital-acquired pneumonia appears to be small compared to the community-acquired pneumonia, because community-acquired pneumonia, we have large data available, and then you see, various surveys have been done. Whereas in hospital, there are different types of hospitals, small hospitals, big hospitals, tertiary care hospitals. So some tertiary care hospital may do the survey or they may not do the survey. And if the survey shows that they have a high incidence of infection, that will bring a bad name to the hospital. Therefore, we may not really get a correct picture about the exact incidence of hospital-acquired pneumonias. But the fact of the matter is that 5 to 15 episodes per 1,000 discharges per year have been attributed to a hospital-acquired pneumonia. So that translates to 0.5 to 2% of all hospitalized patients. That means all hospitalized patients for surgery, for gynae, for pediatrics problem, or for some general medicine problems, or skin problem, whatever it is. And out of this, about 0.5 to 2% can develop, hospital-acquired pneumonia. But when you compare to the younger population, this is much less. That means under the age of 35. Among those who are in a hospital, who are older people, who have comorbidities, they have got a higher chances of developing. But if you do a survey in so for example, a ward where the patients are less than 35, or you go to gynae ward, they have been admitted for some other purpose, like labor and other things. There, the incidence of pneumonia is much less. And now, in the hospital settings, we have different types of nosocomial infection. One can get, the central lines are put and you can get infection. You can get urinary infection. So, yeah, central line insertion and the urinary infections are very common. And that is followed by pneumonia. So, by and large, what I want to tell you that hospital-acquired pneumonia can be prevented if one is very cautious and careful, and especially those who have a high tendency to develop pneumonia, they require specialized nursing care, because their chance of getting hospital infection increases by 1 to 2% per each day of hospitalization, especially when they're admitted in the ICU. Now, I've already told you hospital settings can be small hospital, big hospitals. It can be general ward, it can be ICU, it can be respiratory side, it can be, so for example, respiratory side admitted for some other procedures, not for only for for pneumonia or something, for malignancy, or for investigation. So depending upon the type of hospital, and the incidence of hospital-acquired pneumonia much higher in the tertiary care hospital, please remember, because they deal with all the types of problems. So therefore, the incidence is much higher. Now, so as I told you, it is not 135, it is those who are under the age of 35, they are less prone to develop hospital-acquired pneumonia. Now, what are the risk factors? It is common to most of the pneumonias. Those who are elderly, more than 70 years of age, who have a chronic lung disease, who have COPD, who have asthma, who have got ILDs, and who have bronchiectasis. So these are the people who are likely to develop pneumonias because they can get all this, they can get colonization with the bacteria. Normally, colonization doesn't occur in the lower respiratory tract, that is below the vocal cord. Trachea, bronchi are usually sterile. Okay. Now, comorbidities, you have diabetes mellitus, you have lung cancers, you have renal failure, you have chronic heart disease. So these are the people who are likely to develop pneumonias. And you all know the aspiration. The person may be admitted to a hospital for with a stroke and may be unconscious. And here the swallowing reflex may be affected. There is the tendency for aspiration after vomiting, or the patient may not be able to swallow, not whenever the impaired consciousness is there. So whenever there is these issues of altered consciousness, swallowing issues, gastric distension, so abdominal surgeries, all these things, they have a tendency for aspiration. And again, I told you, those are on mechanical ventilation. MVM is mechanical ventilation. Nasogastric feed. So they have a tendency for aspiration. And past antibiotics, those who have received antibiotics for some other reason, we don't know. That means there could be a possibility that they may be harboring resistant organisms. They have a colonized bacteria which are there, but now they invade. They may be having resistant organisms. Poor dental hygiene, they have a tendency, for aspiration. Immune dysfunctions, humoral, CMI, transplant chemotherapy. This is for all types of pneumonia. But the hospitals setup, you have to think where is the source? Healthcare devices. Healthcare devices, we put catheters, we put tubes, then ventilators. So many equipments are there. So healthcare devices. Environment. It is a closed environment. It is a humid environment. This one, and then the doctors, the staff, they don't take the facilities. Hand washing is not done. They may be having some infection. Healthcare people, so they may be having infection. They may transmit it. So there is a strong possibility of transfer of organism between the staff and the patient to from other patient to the patient. And those who are hospitalization, who have a chronic morbidities and who are this one, there is a oropharyngeal and gastric colonization, and there is a tendency for aspiration. So this is different from what I told you, immunocompromised, then elderly people, all those things which can occur in both the settings, in community as well as in the hospital settings. Now, so risk factors are modifiable. That means they are related to nutrition, immunosuppression, pain control, physiotherapy, prevention, unplanned extubation. So what unplanned extubation means, the patient is already on a ventilator. We have not properly weaned off the patient from the ventilator. Then he has been put on oxygen, ventilator is out, but again we have to re-intubate. And so if you do re-intubation again, there's a chances of getting the pneumonia. So that is what. So these are all modifiable risk factors: nutrition, immunosuppression, pain control. Suppose what happens if you give too much of sedatives, to give too much of pain, there is a tendency for aspiration. And if you may not be doing physiotherapy properly. So this is what is modifiable. So therefore, device-related, minimize sedatives, paralytical agents, avoid gastric over-distension because they can aspirate, avoid intubation, re-intubation, that means unplanned extubation, semi-recommend position in nursing, and then when the patient is unconscious or a patient is on ventilator, you have to do continuous subglottic suction. So environmental, do hand washing, staff education, they should be told. Okay, isolation, microbiological surveillance. Every hospital in ICU or in healthcare setup, you have to do the surveillance, microbiological surveillance. That means the microbiologist has to come to the wards, take the scrapings from the samples from various instruments and also from which are stored, and then also from the wall. And then find out what is the type of microbiology of that environment. Is it a fungus? Is it a resistant organisms? So that we have to do by microbiological surveillance. And now, 60% develop VAP if mechanical ventilation is beyond 48 hours. So whenever we do mechanical ventilation, it should not be for a long duration. So mechanical ventilation post-operative, during operation, and subsequently maybe 24 into 70 hours in any sometimes in some difficult post-operative cases. But who are the one who requires long mechanical ventilation? These are the people who have some neurological problems, or who are not able to breathe on their own. Their ventilatory muscles are weak. They're not able to this one. They have a type 1 respiratory failure. They have a type 2 respiratory failure. So these are the people who require mechanical ventilation. Now, those who are on mechanical ventilation and develop pneumonia, then whatever the cause of the underlying problem is own mortality. Over that, ventilatory associated pneumonia will add further by 15 to 50%. So 15 to 15% additional mortality is already on the over the primary disease for which the patient is admitted. Understand that. So therefore, this complication will make the condition of the patient worse and the mortality increases. So major causes, as I told you, even in ventilatory associated pneumonia, or hospital-associated pneumonia, nasopharyngeal aspiration is the most important thing due to whatever reasons, whether it's from gastric or from oral cavity or from intubation, mechanical or altered neurological status, all these things. And airway sampling, aspirate, ball, this is just to find out what is the etiology. So that is a different topic which I'm going to tell you. Now, depending upon the the problem for which the patient is admitted. For example, the patient is admitted in the hospital with a trauma, has been admitted with trauma. So when the patient has been admitted with a trauma, but otherwise has no, the chronic the health issues, in such cases, you get the community-acquired organisms because they don't, harbor those gram-negative organisms. They're healthy people. They sustained some accident and then they got admitted to the hospital, and then they get a problem there. So most of these people, they get a problem where it is the organisms of the community. Streptococcus, pneumonia, het influenza. So these are the common organisms which causes community-acquired pneumonia. Okay, they are gram-positive organisms, or it could be, Now, the patient who is on ventilated patient, neurosurgical patient, and who have a blunt trauma, and all these injuries, staphylococcal RES is most important. Staphylococcal RES. Blunt trauma, ventilated, neurosurgical problems, they have a staphylococcal RES is most likely. Pseudomonas occur when the intubation is longer. So, for example, after 4th day, then you find resistant organisms coming. Gram-negative organisms, because that's a colonization by the Acinetobacter, Pseudomonas aeruginosa, E. coli, Proteus. So these are the organisms which come in. In the early stage of intubation, early part of this one, hospital-acquired pneumonias, you find that it is mostly the gram-positive organisms. Now, so the the gram-positive organisms responsible to CAP, can also cause the early hospital-acquired pneumonias, and these organisms come Streptococcus and then Staphylococcus, and so these are the. But in the later stages, you get a gram-negative infections. And non-core CAP pathogens can like methicillin-resistant Staphylococcus, MRSA, Pseudomonas aeruginosa, etc. Gram-negative bacteria, they are the non-core CAP pathogens. So these also, they are the main core, non-core for CAP, that is community-acquired pneumonia. but they are the main core pathogens for the hospital-acquired pneumonia. That means MRSA strains of Staphylococcus, Pseudomonas aeruginosa. See, these are, extended beta-lactam producing organisms, Pseudomonas aeruginosa, gram-negative bacteria. So these are responsible for the hospital-acquired pneumonias. Now, so we have to find out the severity of pneumonias. So, severity pneumonia, we have, two scores called the PSI score that is used in the community setting. It is not useful. In the hospital setting, we don't have a definite score for the hospital-acquired pneumonia. The CURB score, that the curve score, that is consciousness, urea levels, respiratory rate, and breathing, So, 65. And so this age of 65, and you assign one score. If the patient has impaired consciousness, urea levels are high, respiratory rate is high, then we have, the breathing issues. So age 65, the maximum score is 5. So they score more than 3, that means they are severe cases, and 4 and 5 requires ICU admission. Okay, so score is 1 is mild, can be managed. I mean, it is not a OPD case I'm talking about. In the hospital, it can be managed in the ward. Curve 2, 3, so they can be managed. They don't require intensive care admission. But those who have got a score of 3 to 5, they definitely require ICU care. When you admit the patient for ICU care, we have to do the maximum proper ventilation and oxygenation. Okay, ventilation and oxygen can be given by non-invasive techniques also. You don't have to admit them for intubation. You can give them high flow oxygen. You can give non-invasive ventilation to a tight fitting mask. So that is, I know only those cases who have a respiratory instability, who are unconscious. In such cases, you have to go in for the mechanical ventilation. So we admit the patient to ICU, not necessarily for mechanical ventilation. That is the point I would like to tell. Now, so what is the difference between the pneumonia due to community acquired and hospital acquired? In the hospital acquired, they can have fever due to some other causes. We don't know. It need not be due to pneumonia. But when they get the fever, which was not there, and has got cough, or the fever is there, but it has become worse. The cough was not there, now it has come. Cough was there, now it has become productive. And then earlier, the patient had raised ESR, okay, some inflammatory marks of rise, procal was plus minus. Now the procals have increased tremendously, very high levels have gone. Earlier, the X-ray showed some COPD changes in asthma, but now you do an X-ray, you find the new shadows have come, new infiltrates have come. That means in a hospital-acquired pneumonia, fever may come, or the fever is there, it may become worse. They may be having cough, but it was mild. Now it has become bad, and now they are producing sputum, and it is infected, yellowish, greenish, all those things. Then they had marginal inflammatory markers. Now it has become very bad. Now you have taken an X-ray. It shows that there is increase in opacities. And then earlier the saturation, everything was okay. Now suddenly you find that the saturation has come down. The arterial blood gas has worsened. Oxygen levels, the oxygen PaO2 level, and then have decreased, and the PCO2 level may be going up. So the pH may be going for respiratory acidosis, or maybe having a respiratory alkalosis because of rapid breathing, and the blood gases are just maintained because in early part of pneumonia there is a increase in ventilation. So you may have respiratory alkalosis also. So that means any alteration in the blood gases, it can give you some idea that the patient is going for the pneumonia. Now, you can have additional information. Patient is getting confused, urea levels are going up, respiratory rate is going up, then hypotension has come up, then PaO2, FiO2 ratio is coming down, then infiltrates new come, it is in all different areas. Then, because of infection, there could be thrombocytopenia, leukopenia. Because of infection, you can have hypothermia. So these are all indicative of an infection and also severity of infection. Now, so the admission for ICU admission, patient is already in the hospital. Now you want to shift the patient to the ICU. Then naturally, if the patient has got respiratory distress, has got tachycardia, and then he is going for septicemia and shock. So this is where then he is going for respiratory failure. He is not, with even with supportive oxygen, and there's altered sensorium, temperature variation is there. So these are the cases where the patient have to be admitted in the ICU. There is no choice. Now, how do you diagnose? I've already told you the clinical features, hospital settings, the symptoms, and yeah, chest X-ray. Of course, naturally, you should be able to make out a diagnose pneumonia. How to diagnose pneumonia by chest X-ray? You find alveolar opacities. What is alveolar opacities? That means opacities which are confined to the alveoli. They're soft, fluffy opacities. They're confluent. When they become confluent, they find a dense consolidation. What is consolidation? The consolidation is there's a dense opacity is there. Now, when there's air bronchogram, that means in that opacity, you are able to see the air containing bronchi that is suggestive of pneumonia. Okay, when the air is absent, then you are not sure whether this is due to the pneumonia or is it due to some other problem. Okay, because all opacities are not pneumonias. There are different causes of lung opacities. It could be non-infectious causes. One may aspirate, but this aspiration does not result in an infection. It can result in pneumonitis, but it produces a pneumonia type of picture. Okay, then you can have ARDS due to pancreatitis, fluid over, so not pancreatitis or some trauma, some other causes. So a patient has got ARDS. ARDS is what? When ARDS is one where you have pulmonary opacities which cannot be due to the heart failure, and this cannot be explained because of the lung collapse. If there is a collapse of the lung, then it is not ARDS. It is some obstruction in the airways. Okay, and there is no pleural effusion, but you have bilateral or opacities, which is not due to the left heart failure, and you give oxygen, but even then the blood gases don't become normal. This is called the refractory hypoxemia. And you go in for the ratio of FiO2, there's a fraction of inspired oxygen, and if you increase the oxygen, from 20 to 60%, 100%, then the PaO2 level should increase. Normally, the PaO2 level is, around 110 when you give 20% of oxygen. When you do high doses of high levels of oxygen, the PaO2 level should go beyond 300. But in case of ARDS, you give 60 liters of oxygen, you give 60% of oxygen. Even then, the PaO2 level is less than 300. When the level is less than 100, even when you do 100% oxygen, then it is called the severe ARDS. So when you have a chest X-ray, so it may be due to hospital-acquired pneumonia. It can be due to aspiration. Not due to infection aspiration, non-aspiration, what is called the Mendelssohn syndrome. As aspiration of gastric content from the stomach, you see acidic, it doesn't have any organisms. But in a chronic patient who has a colonization, then you have got the gut organisms coming. That is different. But in a healthy person who aspirates for whatever reason, then you get acid aspiration. Okay. Then pulmonary thromboembolism, showers of pulmonary thrombi, which has resulted in pneumonia type of picture. Then contusion of the chest, you can have, it can produce pneumonia type of picture. Okay, there is a collapse of the lung due to foreign body or some secretions which has accumulated. So, these are differential diagnoses. Then you have vasculitis. The person has got some other problem. He has got immune disorders, has developed vasculitis, which can produce these type of this one. Patient may be having vasculitis and collagen vascular disease they are known for remission and exacerbation. The patient may develop an acute exacerbation of SLE, may be having acute exacerbation of some other collagen vascular disease, which can also involve the pulmonary parenchyma. So we have to keep all these differential diagnoses. Drugs, the patient in the hospital are given certain drugs and which can produce bronchiolitis type of picture. Drug-induced interstitial pneumonias. We all know they can all produce. Various types of drugs are there. Urinary antiseptics, furantin, sulfur drugs, penicillin group of drugs, anti-epileptic drugs. They can, there are anti-cancerous drugs. They can all cause drug-induced pneumonias in a hospital setting. Okay, so we have to keep all these possibilities. But to make a diagnosis of the pneumonia due to infection, you have to do blood culture, you have to take cal levels to find out whether it's high to say he has got infection. The C-reactive proteins will be increased. You will have leukocytosis with the polymorphonuclear predominance. You have leukopenia also in severe infections. You can have leukocytosis. The sputum may be on visual examination, it may be thick, it may be tenacious, yellowish, purulent, greenish, and you may have red currant jelly. There are different types of sputum. By that you can say whether it's a Klebsiella, whether it is due to for example, due to what you call the Pseudomonas. The different type of by looking at the sputum itself, one may be able to say whether it's a rusty sputum. So visual examination can give you some information. So don't discard the sputum examination. Every time you don't have to do all these culture studies, but visualize the sputum. Then, if they have some pleural infection, they can develop pleural effusion also. Then you see whether they have empyema, whether you can go organisms there. ABG will tell us the severity. I have already told you. If they have got a PaO2 levels, then 60 millimeters of mercury. PCO2 level is going there more than 45. That means they are going for the type 2 respiratory failure. When the PCO2 level, PaO2 level is less than 60, PCO2 levels are okay, then it is a type 1 respiratory failure. So that we have to see. And when they have respiratory failure, that means it's a serious disease. Then because of the infection, they can have deranged liver function test, RFTs also. Some of the atypical organisms can result in, say, for example, derangement of the LFTs. In the hospital also, they can get viral infection, but the viral infections are not so common in hospital. Okay, these are all common in these community-acquired setting. Okay, so serology, therefore, doesn't have much value. RFT, LFT does not really help us to find out the etiology, but it will indicate that the patient has got septicemia or has got a serious infection. Okay. Otherwise, when you do RFT, LFT in certain settings, in viral settings or atypical infections, then the LFT may be deranged in some of these cases. So, differential diagnosis, I've already told you. Aspiration, ARDS, LVF, pulmonary thromboembolism, pulmonary hemorrhage, we can produce what is called the occult bleeding. You can have diffuse opacities in the lung, what is called renal-pulmonary syndrome, Goodpasture syndrome. Here, what you find that you find opacity, but he may not have frank hemoptysis. He may bring out some, the slightly pinkish sputum. So, but you will not have frank. But the pulmonary opacity worsens, oxygen desaturation occurs. And if you examine this pulmonary, exudates which come from the lungs through the sputum, examine the sputum, then you find evidence of blood, hemosteroid-laden macrophages. The macrophages have already engulfed this, the hemoglobin, and hemosteroids are present inside the macrophages. And if you do Pearl stain, PEARL, Pearl stain, then it is positive for hemosiderin. So hemosiderin-rich pulmonary sputum, and then increasing opacities and worsening hypoxia. So they are suggestive of pulmonary hemorrhage, that is pulmonary vasculitis, which can occur in Goodpasture syndrome, in uh, C ANCA, P ANCA positive vasculitis. So remember these conditions. Then, cryptogenic organizing pneumonia, BOOP, that is rapidly occurring pneumonia consolidation, but there's no infection. It is an inflammation. We don't know the cause. It is a type of interstitial lung disease, acute interstitial lung disease, where the patient can come with cryptogenic organizing pneumonia, or what is called BOOP. Okay, bronchiolitis obliterans with organizing pneumonia, BOOP, COP. So they're all non-infective causes of the pulmonary infiltrates, not infiltrates, consolidation, solidification of lung due to non-infectious cause due to vasculitis or inflammation, whatever it is. But we are not able to find out the etiology in this case. Therefore, they are called idiopathic. In vasculitis, we know we don't know we know that it is caused due to the production of certain the uh, this it is you have antibodies against the ANCAs and CRP ANCAs. So that is that results in the inflammatory pneumonias, and this inflammatory pneumonia is non-infectious. Drug-induced, I have already told you, trauma to the chest produces pulmonary contusion. The patient has a blunt trauma, fallen, and at that time there was no breathing difficulty as such, except little bit of contusion. And later, but with the trauma, there was a pulmonary congestion, and then there was a slow exudation of the little hemorrhagic blood into the lungs. So it causes a pneumonia type picture. They may not have fever, but they will have hypoxemia and increasing opacities, because inflammation peaks up in the early few parts of 2 days of trauma. So the inflammation peaks up. Then malignancy also can produce this type of picture, but they will not have typical features of infection. Now, how to diagnose in a hospital setting? You do culture, you find that we are not able to identify because there are different type of colonizing organisms. And today we have a multiplex of PCR panels, so that can identify various, viruses, bacteria. So they have, in various microbiological labs. So this is the ICU panel. So this is the community panel, where they have got the PCR panels, where you can make a diagnosis based on the genetic markers, molecular markers of the organisms. So just like Gene Expert, which you use for the diagnosis of tuberculosis, in the same manner, we have got multiplex PCR panels by which you are able to detect resistant organisms like MRSA, methicillin-resistant organisms, extended spectrum of beta-lactamase producing enterobacteriaceae like E. coli, then Pseudomonas and Acinetobacter. So Klebsiella, so all these organisms can be detected. Then, so where different, the companies have come out with various panels, and they are useful in early diagnosis. Because when you use these multiplex PCR panels, it shortens the time of period from in the emergency report. You can get the reports very fast. Okay. So otherwise, we give empirical antibiotics, we take the sample, and culture will take 48 to 72 hours. Then, they may not do all the drug testing, resistant isolation may be difficult with the limited lab facilities by conventional methods. So, so we have biomarkers. Biomarkers have already told you C-reactive protein and ProCal, but ProCal will help us to guide the duration of antibiotic therapy. If you do procalcitonin, it is going up, that means the infection is going up, picking up. And you put the patient antibiotic, it is coming down, that means there is a response. So it is useful. Okay, procalcitonin will tell us that there is infection, but we are not sure. Anything more than 5 and all, it is a severe infection. And if it is above 2, it may be mild. So that there are laboratory, variations and the levels. So if you see your investigation report, you find that the ProCat value from a 0.5 to 2 is mild, maybe 2 to 5 is moderate, and more than 5. ProCal means it is a severe pneumonia, a severe infection. Okay. But then we cannot decide whether to start the antibiotics or not. Okay. To decide the antibiotics, you have to take into consideration other factors also. Okay. Now, that is the point. So, it is always better, you assess the risk factors. If the tendency for aspiration, minimize water feeding, remove this, the gastric distension should be minimized. So, control the diabetes, then renal functions should be okay. Then maybe on immunosuppressives, to continue this treatment, the pneumonia may become worse. So if there's the CSF leak, cochlear implants, malnutrition, smoking, so they're all are the risk factors and they have to be rectified. Now, you see, what is the treatment of pneumonia? The treatment of pneumonia, of course, the most important is oxygenation, and then especially who have got a moderate to severe disease, then if they're not controlled with oxygenation, we have to do ventilation, ventilatory support. So oxygenation to nasal prongs or high flow oxygen system or a non-rebreathing mask. So we have various devices by which you can do oxygen. Then when there is hypoventilation or they require a little extra support to that respiration, then you use non-invasive ventilation. Non-invasive ventilation is given if the patient is conscious, his respiratory rate is not very high. The non-invasive ventilation, it avoids intubation. That is the advantage. Because intubation is associated with a lot of issues. Sedation is required, paralytic agent may be used, and then you are putting the tube into the trachea, so it forms a conduit from the outside world. So therefore, they get the chance of getting infected much higher. But when you give non-invasive ventilation through the mask, only thing is that patient cooperation is very required. If there are secretions in the mouth and oral cavities or in the nose, it may be pushed into the lungs. That's quite possible. And if the ventilation is not proper, it may go into the stomach and you may have aerophagia. And then mask-related problem. They may not like the mask. They feel, a local pressure may be there. One may not tolerate. One may fight with the mask. So these are the issues with the non-invasive. In COVID times, we used to use high flow nasal oxygen. High flow nasal oxygen means when the flow rate is much higher than the inspirative flow. Normal inspirative flow should be around 35 or so. When the flow of the external device through which you give oxygen and the oxygen flow is more than 35, that is the inspirative flow, which is normally generated by the patient, then it is called the high flow. When it is less than 35, then it is not high flow. Okay, it is you are giving not 10 to 15 liters is not a high flow. High flow means you are giving oxygen which is much more than the inspirative flow. So high flow, you give 40 liters, 45 liters. The maximum which can be given by the HFMC apparatus is about 60 liters. And when you use such a high flow in a closed circuit, you are almost giving 100% oxygen. Because with such a high flow, the mixing of the air is much less. Therefore, the oxygen that you are giving does not get that much diluted. When you give 5 liters of oxygen, 10 liters of oxygen, although you are giving pure oxygen, but it mixes with the air, therefore you are not able to achieve FiO2 beyond a particular level, maybe 40%, 45%. But when you give it, the polymass, or what you call a non-rebreathing mass, tight-fitting mass, then you may increase the FiO2 level still higher. In HFNC, you give high flow, and therefore you are able to manage high FiO2, that is fraction of inspired oxygen. That means oxygen which gets into the lung after mixing with the atmospheric air will be around, say, 80 to 100% in case of HFNC. So that is what we have to see. So our aim is to see that the patient oxygen levels and ventilator parameters are okay with NIV or with HFNC. And when the patient is not able to maintain these levels or not able to tolerate, or there's a contraindication for the use, for example, there's a facial surgery has been done, then how can you fit the mask? Just cannot fit the mask. The patient has the facial burns. How can you fit the mask? It is not possible. So in such cases, you go in for the invasive ventilation. So I don't want to go into all these details. So that is in a critical care setting, the the treating doctor should know what is the best modality of oxygenation and what is the best modality of the ventilation. Accordingly, we have to choose the type of ventilator, mechanical or non-invasive, and then we have to decide how much of oxygen patient has to get, whether by high flow system or by higher flow rate, but not very high flow, higher flow rate, or a normal flow rate of 4 to 5 liters. But in a patient who has got carbon dioxide retention, in such cases, if you do high flow, then it causes ventilated depression and the carbon dioxide level may go up. So in such cases, we have to give controlled oxygen therapy, wherein the PaO2 level does not normalize, but it is sufficient to sustain the body functions and to maintain the ventilatory drive. When you give high PaO2, and the PaO2, when the PaO2 levels goes up in the blood, then the ventilated drive is depressed, because hypoxia is the most powerful ventilatory stimulant. So when there is a stimulation ventilatory centers, the patient breathes fast. When the depression of the ventilatory centers, there is a hyperventilation. So hyperventilation is one of the features of blue bloaters who are hefty, sleep apnea syndrome, and who have chronic bronchitis, not emphysematous patients, but who have a chronic bronchitis. So these are the people, they have a hypoventilation. Whereas in emphysema, all they breathe fast. They may not have CO2 retention. So in such cases, who have got blue bloaters, sleep apnea syndromes, if you do high flow oxygen, then the carbon dioxide level may go up. Now, this is just to tell you, in a hospital setting also you can get pneumonia. This is a consolidation, dense consolidation. So when there's a dense consolidation involving one entire lobe, and there is a bulging of the fissure, that means there is a high inflammatory, this one, that is suggestive of Klebsiella pneumonia. And when you grow them, then you find the typical organisms can be grown. And when you examine the sputum, it is a current jelly appearance. Okay, so these type of pneumonias can occur also in the hospital setting in the early part of the disease, not in the later part of the disease. Okay, in such cases, naturally, when you have such a pneumonia, then your ABG will show, PaO2 will be low. Normally, the PaO2 level more than 60 indicates that patient is not in respiratory failure. Here, the PaO2 level is 52. That means the patient has got. Now, the patient has gone into type 2 respiratory failure because the patient is exhausted. So, therefore, he is not able to breathe in, breathe out. There is no ventilation proper. So, the PCO is going up. pH is normally 7.4 to 7.5, but in this case, it has come down to 7.3. That means there is respiratory acidosis. And the patient has got anemia. That indicates that there is an infection which is causing some degree of bone marrow depression. We don't know. and as well hypoalbuminemia. That indicates that there is severe, infection. Tachycardia is another indication. Heart is okay because the heart failure is not set in, but there is a sinus tachycardia. CBC is not so high, but the patient is having features of septicemia. Procal level is 6.5. Normally, more than 5 is severe. So when we have to see whether there is some cause elsewhere, whether it is gram-negative organisms, abdominal causes, ultrasound abdomen is normal. When we grow the blood culture, definitely the pure cause of Klebsiella. So blood culture has a role. But when the patient is on multiple antibiotics, blood culture may be negative. We don't know. In such cases, naturally the patient requires oxygenation, IV fluids, steroids. Now, steroids should be given if the patient has got adrenocortical deficiency because of the stress-related issues, because of severe infection. In these cases, we don't give high dose of steroids, but we give steroids, hydrocortisone, 50 milligram every 6 hours in the ICU setting. Give adequate fluids. Antibiotics that you have to choose, which is the right antibiotic. So that antibiotic has to be chosen. Suppose you suspect gram-positive organisms, Klebsiella, then clarithromycin augmentin is a good drug. But then, if it is MDR, then you have to choose a different this one. So assess the